Well, the next part of our program, I think, is equally as exciting as what we've already done, talking about hormones and inflammation and diet. And we're moving into the part of our program that we're calling Policy in Action. And there has been some incredible work at a state level that we'll talk about here in California, also at a state level in Maryland. We'll get to hear from Jamie Belcedo briefly about federal legislation and what we've been doing at a national level. And then we're going to move into policy breakout discussions. And we really hope that you all will be engaged and want to hear from you about what you think we should be doing and our policymakers should be thinking about relative to maternal mental health. Let me pull up some slides. And I do want to first start by sharing the Maryland policy report. So there's a gentleman who's an attorney who actually ran a commission to address maternal mental health disorders in the state of Maryland. He couldn't be here with us, but we have a very brief video that he's going to outline in this video their policy recommendations for change. And then we'll move into hearing about California. We've got a couple of guests who will be with us to talk about California. Let's see if we can do this.
The Director of Public Policy for the Mental Health Association of Maryland. Thank you very much for having me at the 2020 MOM Conference. I'm excited to give this presentation on the report of the Maryland Task Force to study maternal mental health. In my role as Director of Public Policy, I actually staffed the Maryland Task Force to study maternal mental health for the past year. It was a really good process, and we came up with some really good recommendations. I'm going to go through them with you right now. Real briefly, I'm sure many of you know this, 1 in 7 women will experience depression during pregnancy or in the first 12 months after delivery. More than 400,000 infants are born every year to mothers who are depressed, making perinatal depression the most underdiagnosed and untreated obstetric complication in the United States. PMADs affect women of every culture, age, income level, and race. The adverse effects on health and functioning of the mother, infant, and family, and they're treatable once recognized. 50% of all mothers who experience these disorders are never identified. And it's in that context that the Maryland General Assembly in 2015 decided to create the task force to address the unmet need in Maryland. The group met multiple times to gather information, review literature, share resources, and develop the recommendations that are to follow. The group of work was divided into several different work groups, and again, I think we came up with some really good recommendations. Going through the data in Maryland that kind of drove the recommendations, there are approximately 72,000 live births in Maryland every year, and the prevalence of perinatal mood and anxiety disorders represents the national averages. Mothers delivering between 2004 and 2008 and between 2012 and 2013 in Maryland, 14% of them reported having symptoms of postpartum depression, and you can see the demographic breakdown here. About 20% of mothers, 2009 to 2013, reported symptoms of perinatal anxiety, and there's a similar breakdown, as you can see here. Notwithstanding this prevalence, a significant stigma persists around issues related to maternal mental health. The Healthy New Moms group, which is a group of my organization, a campaign of my organization, the Mental Health Association of Maryland, held focus groups between February and April of 2015, and what they found was really pretty serious frustrations among the public about a lack of input and information from their providers. The evaluation concluded that pregnant and postpartum women expect to receive information and access to treatment from their medical providers, but currently find little support. There are similar frustrations among the providers. The participants reported that there is little information available for providers and even less training specific to perinatal mood and anxiety disorders. The report also found that many providers are uncomfortable addressing mood disorders and are not familiar with resources that do exist, preventing them from feeling confident in addressing patients' needs. those findings are reinforced by a recent survey of OBGYNs conducted here in Maryland by the Johns Hopkins Women's Mood Disorder Center, who a representative of that, the Women's Mood Disorder Center, actually sat on this task force. And the survey found that 80% of those surveyed said they were not satisfied with the number and quality of psychiatric referral resources for their patients. And another 85% indicated a strong desire for additional trainings and or consultations about how to address maternal mental health issues. The survey also revealed that 1 in 4 OBGYNs lack confidence in their knowledge of psychiatric illnesses, medications, and treatment, and that 1 in 4 have a low comfort level in treating depression and or anxiety in their pregnant patients. So with that background, with that scope, the task force came up with the following recommendations. The task force felt very strongly that to really start addressing the unmet need in Maryland, it's critical to improve early identification of postpartum depression and perinatal mood and anxiety disorders. And to that extent, the group recommended requiring maternal mental health screening for all patients prenatally through the first year postpartum. There are several states that require some degree of mandatory screening. But simply increasing screening alone won't solve the issue unless we address the other systemic gaps that have exacerbated the problem, and that's where the other recommendations come in. We need to make sure that mothers and families have information necessary to recognize signs and symptoms when they occur, which is addressed by recommendation number 2, require healthcare providers to offer maternal mental health information and resources for care to mothers and families at various times during the perinatal period. And there are many states that require this type of information distribution. It is also critical to develop continuing maternal mental health education for providers. As you saw in the focus group and survey results, providers are eager for more educational opportunities and resources in addressing this issue. So the third recommendation is to require the development of free maternal mental health CME and CEU trainings, including online options. Now, it's noteworthy here that a portion of the task force supported a stronger recommendation in this area. While not a unanimous opinion, these members recommended a training requirement for certain providers, such as pediatricians, internal family medicine providers, obstetricians, psychiatrists. Some states mandate the availability of provider education, but none mandate that providers complete CME credits. The fourth recommendation, again, going back to the eagerness amongst providers for more resources, is the expansion of BHIPP to assist obstetric, primary care, pediatric, and other providers to address the emotional and mental health needs of pregnant and postpartum patients. Now, BHIPP in Maryland is the Behavioral Health Integration and Pediatric Primary Care Program. It's designed to support primary care providers in assessing and managing the behavioral health needs of their patients from infancy through young adulthood. This program was modeled after the Massachusetts Child Psychiatry Access Program, or MCPAP, which also just recently expanded their program in a similar way. Again, to address, they created MCPAP for moms to address the emotional mental health needs of pregnant and postpartum patients. In line with the need to provide greater education and resources to providers and the public, the task force recommended the development of a multifaceted maternal mental health initiative which included a number of recommendations, 5 through 8, related to the initiative, establishment of a specific office in the state to coordinate and implement ongoing advocacy, education, and awareness and treatment efforts, expand state maternal mental health public awareness campaign efforts, develop, maintain, and promote centralized educational materials and resources for patients and families, create a centralized multicultural online provider toolkit to assist in the identification and treatment of PMADs. The group also wanted to develop and expand peer support networks and navigation. Peer supporters' experience and institutional knowledge put them in a unique position to offer support to pregnant women and new mothers. We have several organizations doing this kind of work here in Maryland, but they're operating on really a shoestring budget. They desperately need more resources to reach more people, and so the task force recommended expanding those ongoing programs. The group was also interested in further exploring the use of maternal mental health navigators who are similar to peer support specialists, and that they promote better health outcomes by helping obstetrical patients maneuver a complex system. The group recommended incentivizing the use of evidence-based practices and the establishment of specialized maternal mental health outpatient and inpatient programs and mother-baby units. The group wanted to make sure that we address comorbid maternal mental health conditions, ensure coordination and integration of treatment for both mental health and substance use disorders, and adopt strategies to address unique needs of pregnant women and new mothers with other comorbidities, including perinatal loss, high-risk pregnancies, and intimate partner violence. The group recommended expanding access to paid family and medical leave so that working mothers and their families have the time to avail themselves of the services that we've been discussing. And finally, the group recommended creating a standing maternal mental health commission to guide state policy and decision-making. The group brought together a lot of really passionate people and experts to come up with these recommendations, and the group felt really strongly that this is just a starting point and that the work needs to continue to make sure that we're addressing this issue. Real quickly, I just wanted to mention that obviously some of these recommendations lend themselves to legislative fixes. Others do not. They will require advocacy more at the systems level. But for even those that do lend themselves to legislative fixes, as any of you that have worked to pass legislation know that just because you have a great idea doesn't mean there won't be political wins, budgetary constraints, and opposing interests that make it difficult to accomplish everything that you want to do. So there has been a bill introduced in Maryland this year to start addressing some of these recommendations. It's a first step. It's a critical step, but a first step towards the development of a comprehensive and robust maternal mental health system of care in Maryland. The bill requires our Department of Health to collect and disseminate maternal mental health information and tools for the public and practitioners. It requires them to develop CMEs and other training programs to improve early identification of perinatal mood and anxiety disorders. And it requires them to work to expand the BHIPP program, the psychiatric consultation program that I mentioned earlier, that's modeled after MCPAP, work to expand that to address the mental health needs of pregnant and postpartum women. So I know that was a kind of a rush through it, but those are the recommendations of the task force to study maternal mental health. Again, my name is Dan Martin. My information is here on the screen for you. And if you'd like to read the full report, the link is right there at the bottom of the screen. So thank you very much. I appreciate the time.
He's not with us online, but thank you, Dan. Great.